July 13, 2021. And our next patient we're getting started with is having Deuk laser disc repair done on the lower back. Sir, it's Dr. Deuk Majan. We're going to get started, okay? The first thing I'll do is give you some numbing medicine. And the anesthesiologist is going to take the edge off any pain. Once we get into the disc that we need to get into, then we're going to put you to sleep so we could do the surgery. Okay? I just need you awake for the beginning. Like we talked about before, if you feel pain, just say ouch. And then tell me if it's in your back or your leg, okay? Ouch, back, or ouch, leg. All right, we'll get started. So he has a very scoliotic spine, and we're not here to fix scoliosis. That takes huge surgery with screws and rods, and honestly, it's unnecessary about 90% of the time when it's for degenerative conditions and back pain. So our goal here is to get rid of the back pain and leg symptoms. This patient has back pain. He has leg numbness in both legs, and he has weakness, okay? So we're gonna go in and unpinch the nerves, and we're gonna treat his back pain. So left side is where I am, 3, 4, 4, 5 on this side. You're gonna feel a little pinch, and we're going to put some numbing medicine in, okay? All right, just bear with me. Now, because of the scoliosis, I'm going to have to adjust my trajectory about where I'm going. Is that uncomfortable? A little bit? I'm sorry. So just so you know, when you were out, we had other anesthesiologists. One of them in particular did a great job. When I poked the patient, they didn't respond. They were comfortable. I don't know what he does, if he gives some Versed or something right in the beginning. But yeah, but they don't respond. So maybe it needs to be a little more. I don't know. Yeah, I would go look at the chart and see what they did. Yeah. Yeah, but see, he's like lifting his body. He's clearly uncomfortable. I don't want that for these patients. I want them to be totally comfortable. But to do that, I need your help. So I would just look at what Pettit did. All you guys do things different, and I just want to make sure the patient's super comfortable. All right, so we're going to start on the left side. Blood pressure looks good. Let me know if you're feeling pain, okay? You'll feel a little poke here and there. Let me know if you're feeling significant pain and where you're feeling it. Shot? So I'm looking at the x-ray. We're doing an AP, which is front back view. My goal is to get to 3, 4, and 4, 5 on this side. And I can tell you can see from the curvature it's not going to be easy to do. Hopefully I can do it with one incision. Let's go lateral. But this is another one of those cases where, again, the hardest part of the surgery is gaining access to the spine. And what does that mean? It means going from where we are to the point that I'm going to repair, which is the annular tear in the back of the disc. And to get there, I have to go through the skin and soft tissues, okay? So we're gonna first get our x-ray machine, which we're using to navigate. Let's line up at 3, 4 first. Okay, so probably need to go south just a little. It looks like that's 3, 4 there. I would say ½ an inch south at most. All right, that's too much. You want a full inch. So come back ½ an inch. All right, now you're going to need to wag it and orbit it to get through the L3-4 disc space. So it takes a little time to line up the spine with the x-ray machine because this patient's spine is not straight. If the spine was straight from a lateral view or side view, then it would be much easier to do. But because we're dealing with twisting of bones, that's better. Because we're dealing with the twisting of bones, we need to make adjustments to the x-ray machine to kind of angle through the twisting area to straighten it out, so to speak. Again, we're not straightening the spine out. All right, I think we got some orbital issues we have to deal with. Let's try that and see what happens. I don't know if that's better or worse. You think so? I don't know. I'm not convinced yet. Let's stay here for now. Let's try a little more on the orbit. That might actually try a little more. Yeah, it's pretty severe scoliosis at 3-4. I can't really tell if that got better. I think it got better, right? You think it's getting worse? All right, try it. Yeah, I mean, I see the pedicles are falling out of alignment, but I think that's worse. I mean, I see the pedicles. Let's try a little more and see what happens. You may be right. Yeah, that's worse. Let's go back the other way. All right, keep going. That's better. I think that is better. I think you're right. Try the other way. Keep going. And keep going. So we're just trying to get the spine and the fluoro machine lined up. I'd say try a little bit more. And a little more. No, that I can't tell, but I think that's... definitely a wag issue as well. Let's try a little wag. I mean, you can see the pedicles of 5 nicely, huh? Yeah. I think from a wag standpoint, we're close. Maybe a degree. That's a little better. The question is the orbit. Where are we on the orbit? And that's what I'm struggling with right now. So let's see if I can get a little closer to the spine to help us out. Are you comfy? Shot? And what I'm aiming for... all right, shot, is that facet joint. And as always, shot, we're interested in getting in and shot, just kind of wrapping around it from the side. That's always our goal. By just getting around the facet joint, we can access the foramen, shot. And by accessing the foramen, we can safely get into the disc. That's our ultimate goal, is fixing the disc, shot. It's a little higher than I want to be, but let's try a little wag. Give me the wag control. It's hitting something. Go. What's it hitting? The arm board?
Go more.
Yeah, the arm boards. Okay, who's in charge of the arm boards?
I'm in charge of the position, sir.
Yeah, so are the arm boards as far north as they can be?
Yes, yeah, because if not, the patient is going to be too, I mean, the shoulder of the patient is going to.
Shot. Mm-hmm. Well, let's keep it right there for now. Guys, the arm boards, if the patient's in surrender, okay, their elbow's here, the arm board should be right there. It should not be down here. It needs to be, at the end of the arm board, needs to be right at the furthest north portion. You can get it by keeping the arms in a proper surrender. Okay. Shot. Where do you feel that? Shot. Where? How far down your leg? Where? But how far down your leg? Above the knee. That's facet, typical facet. Even though we have to be careful because we're at 3-4. It could be the exiting 3. Shot. Let's get an AP. And by the way, you're too far north. I don't know if you realize that. We're seeing like up into the thoracic spine. It should be further south. So for those of you watching these surgeries, these are live broadcasts and they are not edited, and they are not edited for niceness and TV. They're literally live streams from an operating room where we do spine surgery. Go back lateral so that you all can see what's done in the operating room, how we deal with situations, how spine surgery is really done, what it takes to do it successfully. But, you know, it's not a movie that's been filmed and edited and, you know, it's perfect. It's a work in progress and it's real time. So we don't have editing and everything. This is just straight up. You get to see how it is. Where do you feel that? In your hip? Uh-huh. Shot? Where do you feel it? Shot. Well, I don't know how I got in there, but I got lucky. All right, AP. I believe, so you can see the tailbone at the bottom, sacrum. Then you got the first vertebrae is 5, then the one above is 4. And clearly the needle is at 3-4. So I feel good about the level we're at. It's supposed to be at 3-4. All right, so we're probably somewhere around the entrance of that disc. Just in the beginning. Let's go back to a lateral. Just entering the disc. Not yet. I'm not entirely happy with where we are. The reason why we're at the entrance is that the bone above is slid to the right, and we're on the left, obviously. And so we need to keep going to get fully into the disc. Shot. All right. And there's a way to know we're in the disc, which we will use this technology now, unfortunately, because it's earlier than I want to use it. Are you comfy? All right. We're just going to put a little bit of dye. You feel that? So, AP, where did you feel that in your back? Is that where you typically get pain? All right, that was the L3-4 disc. You just have a severe curvature here. Yeah, so we're in the disc. You can see that. We've basically done a discogram at L3-4, but I didn't put a lot of pressure. Not that we normally do, but I barely lightly injected it just because I want to see the inside. I want to see where the dye goes. So If we're in the disc, you'll see the inside of the disc with the dye. It'll fill the inside of the disc, and then when we take the x-ray picture, it'll block the x-rays, so it'll create a dark spot right where the dye is, and that's what we've done, okay? So you can clearly see we're inside the disc at L34. So that's good. It's an incredibly challenging disc to get to, but we got there. And I made my incision now on the left side, 7 millimeters. This is a Band-Aid incision. It's literally a 1/4 inch incision. We're going to do the entire surgery through a 1/4 inch incision. And basically it's been bloodless as well. We don't lose blood during the surgery. So it's a bloodless Band-Aid incision of repairing 4 areas of the disc that are damaged, causing his symptoms. Now we're going to be able to put him to sleep, but not quite yet. He needs to be awake to help me for this first part. He's doing a great job. Okay, let's go shot and then lateral. So the next target is going to be the disc below. You can see it's got a giant facet joint off on the left side, and the spine again is starting to curve away from the left side right at the L45 disc, which is where we're headed for. So we need to line up the spine. Jordan's going to get the pedicles lined up of L4 and L5. Again, you won't get them perfectly lined up to like you would in a normal spine, only because there's scoliosis. When a patient has scoliosis, what it means is their vertebrae are not lined up. And anytime you get a side view x-ray, you're going to see that the pedicles for the vertebrae above and below the disc you're looking at are not going to line up perfectly, but you try to get it as close as possible. All right, that's getting closer. We want that 4-5 disc. We want to shoot our view straight down the L45 disc. Okay, so I need a little more wag. That's really close. That's almost as close as we're going to get it. I would like your fluoro to be further south. So this beginning part of the surgery is really about getting, and then you're going to have to re-wag. So a little further south and re-wag. The beginning part of the Deuk laser disc repair surgery is all about navigating from the outside world where we are here into the tear in the back of the disc. And we go through a hole that's already there in the neuroforamen. That's pretty, that's close. That's really close. I think that's probably maybe as good as we can get. Let's deorbit it a little bit if you haven't already done so. So for our viewers, and now I think the deorbiting is fine. So for our viewers, John, can you watch here?
Yes, we're overhead now.
You're watching, but can you, you're watching the eye in the sky?
I can do either the fluoro or the
Are you eye in the sky?
Yes, I am.
So pretend this is the fluoro machine, folks. All right? And wag means moving it like this. Okay, this is wag. All right? And we're trying to line up the spine because he has a curvature. And then orbit is like this. Okay? And then up and down are like this and this. So up, down, orbit, one way or the other, and then wag. Okay? And then there's one more axis of rotation, which we don't use, and it doesn't have any bearing on navigating. All right, let's get the lights down again, and let's go back to our lateral view. So we're trying to line, rather than moving the patient to line up with the x-ray, we're moving the x-ray to line up with the patient. I think we're off there. We need to change the wag. Let me have control of the wag.
Wag's released.
Shot. Huh. That's better. Right there. Lock it in. Lock it all in. That's as good as we're going to get it. Right there. All right. So we're going to proceed. I'm sorry it's a bit uncomfortable shot, but we're aiming right for that next disc. As you can see. Shot. First thing I encounter is the facet joint. I'm a little higher than I want to be. I'm going to redirect around it. Shot. I'm aiming right for that L45 disc. That's my target. Shot. I feel like I'm right in the facet, perfectly aligned. I just need to get around this facet. Shot, which I'm getting there. A little higher than I want to be. You're doing great. I promise, shot. We're almost there. It's a little higher than I want to be again. Shot. That's more like it. And I use the shot. I use not only the, to guide this needle, I have to make manipulations of pressure here to direct it, but there's also a secret to this needle shot. And it has, and every pain management doctor knows this secret, every good one. Where do you feel it? In your back. In your back? I need your help, doctor. I need you to really be a megaphone for the patient. Okay, where do you feel it? In the back?
It's okay now?
All right, but it's not down the leg. AP? Yeah, so since we're navigating around the nerve root right here in the foramen, we have to be careful that if there is any nerve root sign, like a pain shooting down the leg, we have to pull back and redirect and go a different route. You can't go through the nerve root, okay? That's really bad form. I feel like I'm right on the herniation. I am. Let's go to a lateral view, please. So you can see the pedicles of L4 and L5 above and below the tip of the needle at L4-5. And you can see the scoliosis of the spine. Yep, we're getting there. I'm very happy with that. Where do you feel it?
In his back.
Shot. AP. So I'm happy with that positioning. I feel like we're inside the disc. We went through the tear that's causing all the pain. So we've locked down L3-4, L4-5. I believe we're inside the disc. I could do a little discogram again just to verify that. Just to make sure you're where you want to be inside the disc. So you should see the discogram material, which is IsoView shot. You should see it go into the disc. There it is. So we're inside the disc. It's a great way of confirming that. I don't normally have to do that, but when you're dealing with such odd angles of the spine, you're not 100% sure. You need to be 100% sure you're actually inside the disc. Now, I use a lot of things to figure that out. One of them is feel. I feel the needle passing through tissue, and I can feel the tear and the herniation. I can feel it, and I felt it, but I need to be 100% sure. So I can't take any chances that we're not feeling it. You feel anything there?
He said no.
All right. Shot. So now I've got to try to get to the L5S1, and in the last surgery we did I wasn't able to because of severe degenerative changes in anatomy. Let's go back to a lateral view. By the way, I checked on the patient we just did surgery on. She's doing phenomenal. She has no pain. We were not able to do her L5S1. We did her L4-5 and she had 11 out of 10 concordant pain. But it's she's very happy and she's on her way home right now, which is actually the hotel. Okay, that's perfect at L5S1 right there. And my gosh, look at that foramen. It actually looks really nice. So it's kind of teasing me. See that foramen? It's amazing, huh? You're okay, shot. Yep. All right. So you don't move around. You're doing really good. Okay, you're doing really, really good. All right. Question is, what are we bumping? That may be the iliac crest. Well, the foramen, you could see when the patient moved, it went away. So we're going to have to probably wag a little bit. Let's get an AP first. I think I'm up against the iliac crest. If I'm up against the iliac crest, I'm going to have to approach this through a more rostral entry point. I'm going to have to go higher up. And yeah, we're up against the iliac crest. Pull the fluoro, or pull it a little bit to you, and you'll be able to see that we're bumping up against the iliac crest. Yep, there it is. Okay, so I'm going to have to start further up. Let's go back to a lateral view. I need some numbing medicine. Our patient is visiting us from out of state, no less than out of the country, as a matter of fact. I'm just giving you more numbing medicine. I apologize. Any way you can make him more comfortable. Honestly, I'm not used to this. There is a way to do it. I just don't know if it's propofol or what it is. Oh, trust me. You're dealing with a neurosurgeon who knows a lot. The only thing I don't do is go through the anesthesia records and figure out what you guys do, but that's something you can easily do. Yeah, I would do that. Yep. Yeah, I know propofol is going to put him to sleep for a little bit, but honestly, I think it may just be some Versed in the beginning. Yeah, the time when I need to know the most about feedback is going to be when I get down docked on the facet and I start coming around it to the foramen. But everything else to that point is I don't need the feedback. Yeah. Shot. I apologize. All right, let's get the fluoro lined up a little better. You okay? All right, let's try a little more numbing medicine here. No, deep. I'm going to give you a little more numbing medicine here, okay? Should make things a little better. All right, so we're going with what? I still think it's not clear like it was before. So let's wag again. Just do a wag and take a shot. Don't lock it. Just do a quick wag, hold it in place, and do a shot. I think it's the other way. Shot. There we go. Lock it down. That's perfect. So typically when patients contract their flank, that's when they're going to lose the view. Shot. Shot. Every time he contracts his flank, we lose the view. Shot. At least we're heading in the right direction. Shot. Let's get an AP. So by watching these surgeries, you get to experience what the surgeon experiences. You get to see the difficulties we encounter throughout surgery. And believe me, there's a lot of them. You okay? Yeah, we're so close. Just hang in there. All right, let's go with the lateral view. Nothing down the leg? You're doing great, by the way. I apologize, it's uncomfortable. But this is the worst part of the surgery, is the very beginning. And then once we put you to sleep, you won't feel anything. Okay? Trust me, it gets better. Where do you feel it? Back again? In the back? Yeah. We're right near those painful discs that we're here to fix. Don't move. You've got to get them a little more comfortable. Nothing down the leg? Huh?
No.
I don't know if it's anxiety or what. I know anxiety feeds into it. This is a terrible shot. I need better than that. He was moving last time, so you should reshoot it just to see where he is. Okay? Before you start moving everything around. All right. Awfully close. We're so close, okay? Hang in there. Where do you feel that? All right. Left side's fine. Miracle of miracles. That, I'm very happy to achieve that. We're in. So that's beautiful. It's amazing what happens when our patients lay still. It makes navigation so much easier. All right. So it's a fine balance, folks. You have to understand we can't snow the patient, otherwise they're not cooperative. And an uncooperative patient for awake surgery is not possible. You can't do awake spine surgery or any surgery with the patient who's not cooperating. And by not cooperating, we mean a variety of things, but mostly movement. Okay? Mostly movement. So awake surgeries are generally safer than asleep surgeries as long as you're able to do it awake, and there's a lot of factors and variables. Some of them include, for example, maintaining adequate blood pressure and pain control. So for example, somebody who's in a lot of pain, how does your body respond to pain? Well, number one, you're going to reflexively move away. So there's movement. Well, we're trying to line the x-ray up with the patient's spine, so any kind of movement's going to throw everything back out of alignment. Then we got to try to find it again by searching around with the x-ray machine. That's not terrible, but I think we can do better. We're going for L4-5. I don't know. I think that's worse. We got a little orbital stuff going on. So, and for those of you wondering, what am I looking at? I'm looking at the back of the vertebrae. Okay, the back of the L4 vertebrae. There are, I know the geometry and 3D anatomy of the vertebrae, and I'm seeing these little pointy areas at the bottom of the L4 vertebrae in the back there. It's the end plate, and I'm looking for a realignment, and we're not far off, but I'm looking for realignment of those, of the back of the vertebrae on orbit. And now I'm looking for WAG. So now I'm looking at the pedicles and the disc space, like shooting through the disc space. And so you have to orient the fluoro machine to the patient's spine properly, otherwise that looks pretty damn good to me. Keep that right there. So I can see the bottom of the pedicle at L4 lines up on right and left, so that tells me we're shooting pretty much parallel to that pedicle. The disc space lines up, and then the back of the vertebral body and the inferior end plate of L4 lines up right to left, so there's no overshadow. That's the orbital change. All right, now I got to get into this disc space. So once again, I'm going to use the standard technique, the Deuk technique, a Deuk spine technique, if you will, of docking and then slipping around. Just got to make sure the trajectory lines up well. Our patient's, I believe, a little more comfortable right now. I don't make any big movements, if you notice. Everything is small. Everything is minimal. And by the way, in case you're wondering, I am feeling with every movement. I'm like feeling with the tip of this needle. Hard to imagine, but yes, you can. You can feel with a needle. You just have to really pay attention. And by feeling the different tissues, I'm kind of getting more than just a visual through the fluoro, but I'm getting a feel of where I am at, if that makes sense. And the really good surgeons are able to feel tissues with their instruments. The instrument becomes an extension of the surgeon's finger. Shot? Or whatever part you're using. Usually it's fingers. So I'm running up against, I think, a little hypertrophied facet here. Shot? So I'm a little higher than I want to be, and I'm getting deflected up by that. It's really the superior articular process of L5 that I'm getting deflected up by. So I need to redirect. And that's what I've done. Okay? I'm redirecting. What redirect means, shot, it means I back up and I come in at a slightly different angle. That's what redirecting means. Shot. Shot. It's a little lower than I want to be. So I need to redirect again. And I'm feeling the facet. I'm going around it. Shot. But I need to go around it. It's too high. I need to go around it just right. Shot. Shot. So this is why playing video games makes a good surgeon, by the way. Shot. They did a study years ago that showed that the surgeons that played a lot of video games in their youth, shot, they ended up having better technique. Shot. Where do you feel that?
On the right.
Shot. You're doing great. They did a study that showed that the surgeons who actually played a lot of video games when they were younger were better at doing surgery for some reason. AP, let's see where we are. So we're very close. We're right at the herniation on the right side. Now, the reason we're going on both sides of his spine is because he's got leg symptoms on both sides. Mostly left, but definitely on both. He's got weakness on both. And I believe he has, from what we can see, he's got pinched nerves on both sides. So, all right, let me see my lateral. Where's my lateral? You didn't say the lateral. You got to say the lateral every time. All right? So let's go back to a lateral view. You can actually see the tip of the needle on the right side is touching the bone spur from the facet joint on the right side. But we're still about 1.5 centimeters away from the actual disc space. And now I'm touching the disc. Shot. And let's get another AP, I think. Hold on. So I think we're in. We're in. But we're not in like Flynn. Shot. Let's get an AP. I'm not really happy with that. This is the hard part. I appreciate you just bearing with me. You have the lateral there? Yeah. And again, because the patient's so rotated, so I think I need to be a little more medial. Let's go back to the lateral view, please. I'm going to redo it. I'm not happy with it. So I really should, with that lateral picture, I should be past the pedicle on the AP view. I should be past the medial border of the pedicle on the AP view. Okay, just to give you a reference point. And I wasn't. So, shot, even though I'm touching the proper areas, and I know the patient's rotated, so I want to try to reapproach one more time to make it better. And this is really a procedure where you have to stack the deck in your favor. Shot. If you don't, try to gain every degree, every millimeter, then you're going to end up having a suboptimal result. So you can't just be happy with, oh, it's okay. You really got to go for the perfection every time. And when you do get that perfection, shot, then you have a great result. Let's go AP. No, nobody's perfect. The technique will never be perfect. I'm not an idiot. Perfection is not possible, not by humans, but I strive for perfection. If I can get 99%, that's not perfect, but it's damn good. So at this point, we're going to, it's going to give really good results. We're going to make sure we're where we need to be. Are you comfy? All right. Pull this back, please. Keeps hitting my elbow. You're going to ruin the scope. Shot. How bad is that on a scale of 1 to 10? Is that where you typically get your pain? Is that where you get pain in your back? Huh? Yeah. So concordant, 10 out of 10, L4-5. Oh, sorry, let's go with a lateral view. I'm sorry. I should have shown our audience. So let's get the marking pen. Let's turn the light on. I'm going to tell you what we're doing, folks. It's just, we've done this before, and it's, I think, good and useful. But basically, the spine is deep inside here. Can you see this, John? And our patient has bones, vertebrae. For example, here is the tailbone. Okay, it's called the sacrum. And the next bone up is the L5 bone. And then there's the L4 bone. And between the bones, you can put them to sleep. Oh, sorry, not yet. I apologize. I haven't done the other two discs. My bad. You're going to enjoy this later on when you watch because it'll be very informative for you. So here's the number 3 bone, 4 bone, 5 bone sacrum. Between the bones is a cushion called the disc. And for the longest time, we didn't understand why we have discs. And then we figured out that they're cushions between the bones so the bones can move and not grind on each other. But that's all surgeons think of discs as being just a cushion that doesn't have a blood supply and doesn't really have nerve supply. So everyone today is brought up believing the disc cannot be the cause of pain, but there are a few of us that know that it is the cause of pain. And the real question is it the whole disc that's causing pain or just part of it? And what we discovered at Deuk Spine Institute is it's a tiny little tear in the back of the disc, either left side, right side, we don't know, it could be both. When I say we don't know is every patient's different. Some patients it's the left one that hurts, some patients it's the right one that hurts. But a good clue to which tear is hurting, because a lot of people have bilateral tears, one on the left, one on the right, at each disc. A good clue as to which one's hurting is the leg symptoms, because the nerve root runs just past that and it goes down the leg, okay? And you got a left nerve root and a right nerve root. So if the nerve root on the left is causing pain, they're getting leg pain on the left or numbness, tingling, weakness on the left, then it could be that this tear on the left at L4-5 is the one causing the symptoms. The problem with this patient is he's got multiple tears at multiple discs. So I had to figure out using the MRI, using his exam, using his symptom and complaints with his back pain, leg symptoms, and using a EMG when we have it. I have to use all that information to figure out which disc on which side are symptomatic. And in his case, I believe this disc is symptomatic on the right at L5S1. I believe both L4-5 tears left and right are symptomatic. And I believe the left L3-4 tear is symptomatic, okay? He also has herniations above at 2-3 and at 1-2, but they're not causing pain. So I just tested the L4-5 disc, and sorry, it is we said 10 out of 10? So it's a 10 over 10 pain, and it is concordant. Concordant means that's the pain the patient typically feels. It's the right location, okay? He may not have that severity all the time, but the reason people don't have that severity all the time is because they guard. They basically restrict their life. They don't do the things that would exacerbate pain, namely activities, and so they restrict all their activities so they don't get the pain. They walk a certain funny way. They don't do exercise like they used to. They don't play sports like they used to. They don't do a lot of things because it brings about that typical pain. Where do you feel that? Is that how bad did that get on a scale of 1 to 10? What's the highest it went? 9? Is that where you typically get your back pain? Huh? Yeah. So 9 out of 10, L5S1 concordant. And you can see on the discogram that it filled up the 5-1 disc. Let's just come down and show the sacrum one more time just to be sure. Let's move those cables out of the way. Let's just make sure. There we go. So there's a tailbone. There's the first disc, L5S1. And there's a huge tear in the back of the disc. You all see that giant tear back there near the foramen? And then L45 we tested was 10 out of 10. Now we're going to have to test one more. Okay, so let me have my pen. So this L5S1 disc was a 9/10. You're going to get to watch all this when you go home back to Canada. We have a lot of Canadian patients, by the way, because they can't get this surgery in Canada. As a matter of fact, can't get this surgery anywhere else in the world besides Deuk Spine Institute. We're the ones who pioneered and developed it. All right, how bad was that on a scale of 1 to 10? 12? That was the L34. Do you typically get pain up there? All right, guess what? You get to go to sleep now. We're done torturing you. We've confirmed, by the way, that all 3 discs I'm fixing today are the causes of your back pain. And that pain I expect to be completely gone when you wake up without any pain medications, okay? You're going to go back to Canada without that pain. I'm excited for you. All right, count from 1 to 100 out loud for me to hear in Canadian. All right. So for those of you who don't know, some of Canada speaks French and some of Canada speaks English. Keep going, you're doing great. At this point, we're putting our patient to sleep so that, he's completely out for the more painful parts of the surgery. I've gotten his help from the beginning. I needed him awake to make sure I could safely access the back of the disc at L34, L45, and L5S1. So let's just review. I know it's upside down for you. We tested the L45 disc first. It was 10 out of 10 concordant. Concordant means, hey, that's where I typically get pain, right? So what's an example of discordant pain? Discordant pain is pain that you don't typically get. If I take your toe right now and your toe's not hurting you, and I crush it with a plier, all right? I squeeze it and it starts to hurt. Well, that's not concordant pain. That's not pain that you typically have every day. I created that for you. So the pain that he has in these discs is his typical daily pain, just not that severe. But you can see the potential for severity if his activities were restored without fixing these discs, that he's going to get all that back pain. Okay? So then we tested the L5S1. It was a 9 out of 10, and then a L34 was a 12 out of 10. Okay? So you saw him tighten up. You heard him go, oh. And that's very typical when somebody has a painful disc, and we test it with a evocative discography, which is what we did. Well, we got a lot of work to do, so I'm going to get started. Feel free to ask questions. Just type up your question. If you haven't downloaded the Deuk Spine Institute app, feel free to do so. The Deuk Spine Institute app is free. You just type in Deuk Spine Institute on your app store, whether it's an iPhone or an Android, and you can download our app. Shot? And then there's a lot of useful information in the app that will help you if you have questions about back or neck pain. We have our live stream schedule, should be there as well. By the way, John, are you maintaining the schedule online for our live stream surgeries?
I don't know if I have the
Okay.
password to the Google Calendar.
That's one of your things you're supposed to. I
Okay.
guess Sean didn't show that before he left.
He showed me
fine.
it, but I didn't have the password to get in. I never got that. So I'll go with Sunny to get that.
Good job. That's how you solve problems. So our viewers like to get onto the web, talk to Zach as well so they can see it on the app. But there should be a schedule of no names, of course. You never put the patient name, right, John?
Right, never put the patient name. Don't want to violate
You
HIPAA.
never put the patient's name. You just put the procedure. Okay? So DLDR, lumbar, onto that schedule so people can see what we're going to be doing. Just not who we're going to be doing it on. By the way, for those of you wondering, all of our patients sign releases allowing us to broadcast their surgery for the rest of the world to watch. Shot. And all of them agree for the most part. If they don't, we don't broadcast it and we don't stream it. Shot? Okay. I'm heading down to the L45 disc with my dilator. That's the first one I'm going to fix. And I'm going in on the left side. So I'm encountering the facet joint, starting to work my way through the foramen. Remember, this patient has scoliosis, okay? Shot. So there's a curvature to the spine. It kind of throws the anatomy off a little bit. And the x-rays, remember, are not three-dimensional. They're two-dimensional. So they're not going to show three-dimensional changes like scoliosis. So you have to piece it together mentally, the surgeon does, to do the surgery properly. I have to actually imagine the spine in 3 dimensions. Like, my lateral view may be good, but my true AP is not good. Shot. How's he doing? All right, good. He's coughing a little bit. Which a shot. Okay. So our patients are asleep, but they're in what's called twilight anesthesia, meaning they're not intubated, there's no tube down their throat. They are in twilight. And by the way, I could feel that dilator advance into the disc space through the tear because the tear is massive. This is a tear in the back of the disc. You know it is what's called an annular tear. The problem is doctors don't talk about annular tears because they don't understand the importance of an annular tear in a disc. Now, annular tears can happen in the front, sides, or back of a disc. The only place they're painful is the back, okay, not the side and not the front. So when you see an annular tear with a disc herniation in the front of a disc or the side of a disc, like the side, you don't have to worry about those because they don't cause symptoms. It's only the tears in the back of the disc that cause symptoms. And Deuk Spine Institute is producing the very first in the world animation showing how the pain goes from the back of the disc tear up to the brain, to the pain centers of the brain. And we're about to release that animation. Shot? It should be released this week. We've been working on it for months, making it better and better, but we're just about done with it, and you all can have access to it on our website, deukspine.com. We'll post it on our Facebook support group as well, and there we go. And also on our website, our Facebook, and our app. Point is, when you watch this animation, it's a couple of, I think it's like a minute long animation, maybe a minute and a half. You're going to understand why the annular tear is the source of back pain. You're going to understand why the disc is the source of back pain. But this is the first time really in history of medicine that we have discovered the cause of chronic back pain from the disc, and specifically the anatomical structures that are causing that pain. But like every discovery, it's happened somewhere in some remote place usually, and then the rest of the world finds out about it and follows suit. But Deuk Spine Institute is the pioneer. We're the first to treat these annular tears, and I'm the first to publish in the world. We published our findings about treating annular tears as a source of pain in the spine in 2012, 2013. And keep in mind that a lot of patients with annular tears, they have what's called a bulging disc. And a lot of radiologists say, oh, you have a bulging disc. And there's a lot of confusion about what's the difference between a bulging disc and a herniated disc. It's just size. A herniated disc is bigger, usually considered bigger, but a bulge is a herniation. It's just a small herniation, okay? So there's a lot of misinformation on the internet, in textbooks, in medical papers about what a herniation is. A herniation is not unique to discs. Herniations occur in the inguinal region, in the umbilical region, postoperatively. A herniation is essentially when one tissue type passes through another, a membrane. So what's the membrane in the disc? It's the annulus fibrosus. What's the tissue that's passing through? It's the jelly in the center called the nucleus pulposus. That's this stuff right here that you're looking at, okay? Stand by. So when the nucleus pulposus jelly passes through the annular tear, it is a herniation. And a bulge cannot happen without herniation. So a bulge is a herniation, okay? It's just a small one. The problem is that everyone gets caught up in, oh, I have a herniation or I have a bulge. Who cares? The point is you have an annular tear, and it's the annular tear that's the cause of the pain, not the bulge and not the herniation. And that's what's revolutionary. That's what I discovered at Deuk Spine. And that's why we're going to change the world and the way the world perceives pain. I'm only operating on the annular tear / herniation. We're not fusing. We're not fixing the scoliosis. All we're doing is debriding the annular tear. Look at all the scar tissue here, the white stuff. It's all junky. This is all calcified disc. So this tear right here that I'm working on at L45 on the left side, this tear has clearly been here for a long time. And when the tear happened years and years ago, probably 20, 30 years ago, the jelly from the center next escaped into the tear and started an inflammatory process within the tear. And that's what I'm debriding. I'm allowing the inflammation to go away, because the only way the pain's going to stop is when the inflammation stops. And the inflammation stops when I get rid of this wedged jelly. We call it interposed nucleus pulposus. And I debride the annulus. So it only comes through an annular debridement that the pain will go away. And we're the only place in the world that does annular debridement. Deuk Spine Institute right here in Florida near Orlando. You're going to have to travel if you want this surgery done. There won't be any screws and rods. There won't be any metal or plastic. And look at the tear right there. You see that? And look at all that white stuff in there. All that white stuff is calcium. It's called dystrophic calcification. It comes from this tear being so old and inflamed. Chronic inflammation. So it's trying to heal itself for many years through the inflammatory process, and instead of healing, all it's done is create more damage and pain, ingrowth of new nerves and new blood vessels, dystrophic calcification of abnormal tissues that are associated with the annular tear and chronic inflammation. And I'm doing a debridement, and it's the Deuk laser disc repair debridement that is going to eliminate this patient's back pain and leg symptoms. Question, standby laser. So this is the disc that we're doing bilateral. We're going to do both sides because he's actually got tears on both sides that are causing pain. That's what I've deduced based on his symptoms and based on the MRI findings and based on the physical exam. We had one of the doctors who were watching my surgery last week asked, how can you determine which disc is causing the symptoms, which disc herniation is causing the patient's symptoms just based on an MRI and X-ray? The answer is you cannot. Unless a person has only one disc herniation, one abnormal disc, one annular tear, or one bulging disc. If they have one, only one, and their physical exam points to that one, then you can say, yes, that's the cause. But the reality is that most people have more than one bulging or herniated or degenerated disc. They have multiple. And so how do you decide which one's causing their symptoms? So what I can tell you is an average of 2.5 discs per person cause their symptoms. That's what we've discovered after years of doing this. So if you just go and fix one disc, when they have 3 or 4 degenerated or bulging discs, then what's going to happen is the patient will still have their pain. That's because you undertreated them. Can you grab my skirt? I'm sorry. My skirt is sliding down a little bit. And maybe once you pull it up, tighten it. Yeah, a little more. Sorry, my lead skirt. I don't actually wear a skirt. I wear a lead skirt. Even tighter. You can squeeze the hell, pull the hell out of it if you can. You know how to do it, right? You pull that strap towards you, put your foot up on my back, and just pull hard as you can. No, just watch the... That's all right. That's good. That should be good. Thank you. So, basically, we wear lead skirts to protect, certain parts of our body down there from radiation. The radiation comes from that X-ray machine we used earlier. So the reality is that if you're standing 6 feet or closer from the emitter on an X-ray machine like this, then you're exposing yourself to the radiation from the X-ray machine. Now this is diagnostic radiation. This is not therapeutic radiation. This is not treating cancer. This is to make a diagnosis. And so diagnostic radiation, like any radiation, adds up over time to the person who's exposed to the radiation, aka me and my staff. Now patients don't get much exposure because they get one X-ray every couple of months at most, maybe once a year. But if I'm in the operating room 3 or 4 times a week doing 3 or 4 surgeries a week, or if you're like Dr. Patel, my partner, who uses the X-ray machine all day, or if you're an interventional cardiologist where you use it all day, then basically you're exposing yourself to all that radiation. So it's very important that you use lead shield to protect your body. Specifically, you want to protect your lens, your thyroid, and your gonads if you plan on having babies soon, because the radiation will cause mutations in the genetic code of those tissues. Okay, I don't want everybody here freaking out. But as long as you're 6 feet away from the emitter during the activation, you're not going to get you're going to get no more radiation than you would, say, walking outside in the park. Okay? So you don't get really any significant radiation. It's only within 6 feet. And of course, the further you are from the source, the less radiation you get. So what we do here at Deuk Spine, because we want to minimize radiation to our staff, our employees, our patients, is we use, number one, the finest quality X-ray machines. They cost $180,000 each. Unlike the cheap ones that a lot of doctors will buy and use in their practices, like pain management practices, that cost much less. They're old. Those old machines, they release radiation like crazy. So you want to stay away from the cheaper, inferior, older machines, because they're going to be releasing lots of radiation, not on purpose, but just because they're dirty machines. Okay? It's a fact. We use a series of collimators which narrow the radiation beam. So you have to have a technician who's good at what they do, and they use the collimators. All right? Those are the iron or lead windows that close up to shield most of the radiation and keep it in the machine, and only release the parts that you allow the surgeon or doctor to do diagnosis, all right, to make sure the surgery is done accurately. So there's a lot of things we do, including using what's called the pulse mode, where we only release a small burst of radiation at a time, so that it cuts down on the exposure of people to radiation. So there's a lot of things. Whoop, coughing. See what happens when somebody coughs? It puts pressure in their disc. That was pretty cool. He actually coughed and shot out a bunch of blue dye that was still in the disc. Did you all see that? Go back and rewind if you want. But coughing and Valsalva increase intradiscal pressure by 250%. That's why when people cough, usually their back hurts a little more. Any questions from the audience? John?
Yes, we have a couple.
All right. So I just want to, first of all, acknowledge John. John is one of our assistants, medical assistant, and he wears many hats. John is going to go to medical school. He's applied to medical school, and he's now working here at Deuk Spine while he's awaiting his application to medical school to be accepted. Am I correct, John?
Yes, that's correct. I'm still in the process of submitting them, though.
Yeah. So if you're at a medical school and you want to hire John or bring him in, he's going to be a great doctor someday. John is taking over the work that was done by one of our former employees in terms of broadcasting and managing the schedule. And also he works with people who want to come to Deuk Spine to be evaluated, whether they want to come through telemedicine, through Skype, or they want to come physically to be evaluated. John is very involved in getting them here and doing the MRI reviews, doing the video conferences after the MRI reviews. By the way, Deuk Spine does free MRI reviews for anyone who wants to know, why am I having pain? And John is also involved with the marketing team and in clinic helping to see patients and making sure things run smoothly. By the way, all of this is the annular tear that I'm debriding. I'm removing the herniated material, the herniated nucleus material stuck in there, but you can see just how bad all this looks. This is not normal healthy tissue. This is really degenerated disc tissue. And the problem isn't the fact that it's degenerated disc. The problem is that there's inflammation going on in the tear that's sending pain signals up to the brain. And I'm cleaning that tear up to get rid of that inflammation, and the pain signals will stop because I'm getting rid of the inflamed tissue. So it's really understanding what we call the pathophysiology or origin of disease when it comes to back pain is really understanding the source, which is the annular tear. Again, Deuk Spine Institute is currently the only facility in the world that treats the annular tear with a debridement, because we're the ones who discovered it is a source of pain in the back or neck and even in the arm and leg. All right, let's take our first question. I'm just about done with this disc.
Yes, so a YouTube viewer is wondering, does the patient's scoliosis contribute to their pain at all, or is it just the annular tears and the disc herniation?
Great question. So one of our viewers from YouTube has said, Dr. Deuk, does the patient's severe scoliosis or any scoliosis contribute to their pain at all? And the answer is no, it does not. Now, any other spine surgeon you talk to that does deformity surgery, scoliosis surgery, will tell you it does. And that's only because they don't understand the true source of the pain. They've never done an annular debridement. They've never done an annular debridement in a patient with scoliosis. So they've never been able to see how this surgery, this simple surgery, will cure the pain without doing anything for the scoliosis. The only way to fix scoliosis, folks, is to do scoliosis surgery. And scoliosis surgery generally means opening up the entire back and putting in screws and rods and performing what are called Smith-Peterson osteotomies, where you're cutting out the facet joints and you are realigning the spine and then fusing it. So we're not doing any type of scoliosis treatment whatsoever. This patient's scoliosis will be exactly the same before surgery as it is after. We will not fix them 1 degree. However, we will eliminate the source of their pain because it's not the scoliosis that's the cause of the pain. It is the annular tear, once again, that I'm cleaning right now. And this has nothing to do with their scoliosis. Do we need to hear that beep, 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 beep? Or is there a way to... I'm sorry. It's so annoying. I mean, if you have to, you keep it, but I could live with it. It's just that I want to put chopsticks in my eyeballs. All right, what's the next question?
Yeah, so that same viewer was also wondering, how would an aspiring medical student or aspiring surgeon best improve their familiarity with the anatomy of the spine and increasing their expertise? Are there any specific resources that you suggest?
All right, so John, I heard the first sentence, but then I lost you at the run-on. Can you repeat the second half? I heard, how would an aspiring medical student or spine doctor learn more about the spine? And then you cut off there.
They were wondering if there are any specific resources that you suggest.
Okay, great. So yes, there are resources. The best way to learn about spine conditions is to learn the truth. And the truth is not easy to come by. The truth is very hard to find. And here's why. There are over 100 million people with spine conditions that are chronic and need attention, okay? They seek medical attention. And the problem is that there are very few that understand the cause of the pain. Okay? Back pain is the number one reason people visit the doctor. Back pain, okay? It still remains the number one reason. Even though cancer rates have gone down in the United States and developing countries, back pain remains the number one reason to go see the doctor. So there are hundreds of millions of people worldwide with chronic back pain. The problem is doctors don't know the cause of chronic back pain. They call it non-localized, diffuse, idiopathic. They have a variety of adjectives to describe it, but basically what they're saying is we don't know what's causing your back pain. So there's a lot of speculation and guesstimation going on out there in the internet, textbooks, where people think they know what's causing back pain. But you see, the only way to really know what's causing back pain is to have an idea about it and then test your idea and see if you're right. And in the last 16 years I've been doing this surgery plus other surgeries. This surgery only does one thing in the spine and nothing else. It doesn't fix listhesis, it doesn't fix scoliosis, it doesn't fix kyphosis, it doesn't do anything. It doesn't do fusion, it doesn't do artificial disc. All it does is one simple thing. It debrides the annular tear. And in every single one of my patients, we've gotten rid of virtually 100% of their back pain from the disc, okay? Now, what if they have pain from something else, like the facet joints or the piriformis muscle or the sacroiliac joint? Well, those things are not going to get better with the surgery. That's why it's important to understand before the surgery what's causing each patient's back pain. Is it the disc that's herniated? Is it 2 discs? Is it 3 discs? Is it the SI joints, the piriformis muscle, the facet joints? You have to know. You have to be able to tell. Now, for many years while I was learning about back pain, I would send my patients to my partner, Dr. Patel, and he would do blocks. He would basically numb up things that we thought were causing pain. And when he did that, we were able to help diagnose the cause of the pain, okay, by doing those blocks. Now I've gotten to the point where I can actually look at an MRI and examine the patient, and I can tell where their pain's coming from without even doing a block, by using what's called the physical exam. Physical exam is the first thing in medicine that we as physicians use to diagnose illness or problems in a patient. A physical exam. It's very important. It cannot be sacrificed. The problem is doctors today don't do the physical exam anymore. Many of them just talk to the patient and look at your tests, your lab results, your x-ray results. And those things aren't going to tell you where the pain comes from. So we have a real dilemma in medicine. The number one problem in healthcare is back pain and neck pain, and yet we have no way to fix it because the doctors don't know how to figure out the source or treat it. So how do you as an individual figure it out? You've got to study reliable sources of information to understand. If you really want to be good at it, come work at Deuk Spine Institute as a medical assistant. You will learn all the causes of back and neck pain, and you will see how they're treated properly. And the other thing you can do is go to our website. You can go to our app, the Deuk Spine Institute app, and read about different causes. But honestly, if you want to be an expert at diagnosing and treating chronic back and neck pain, you need to come here and you need to work for us and learn on the job. We don't have a book. We do have, good educational resources, but, in the end, it's not just understanding the causes of back pain, but you have to be able to differentiate which one is the cause of each patient's back and neck pain. And for every person, the cause is a different combination. You understand what I'm saying? All right, what's the next question? We're just about done on this left side with the L4-5 herniation and annular tear. And next I'm going to go to the other side and take care of the, I'm going to go to L3-4, and then we're going to go to the other side and take care of that. Great questions, by the way. Keep them coming. I love questions. Questions are a really good way to understand what's going on.
So
Hey, one more thing. Whoever asked that question, I would love to publish a book on the causes and treatment of back pain and neck pain. And so I thought about doing it, but if there's an aspiring author out there who wants to work with me to publish, I'd be happy to do that. Just contact Deuk Spine and mention it. All right, John.
Yes, before I get to the next question, we have a class at CNI watching Miss Kelly's class, and they would love for you to say hi.
Hi, everybody. Tell us where you are. Are you in California?
I'm not sure. I'll wait. I'll let you know as soon as they respond. And then our next question that we have is asking, how does the removal of the mattress stuffing or the herniation alleviate the pain?
I'm sorry, John. I got to cut you off. Your voice is your volume is too low. We need a little bit louder. If you can just bring your volume up a smidgen.
Yep. How's this? Is this better?
Much better, thank you.
Okay. And then the next question is, how does the removal of the mattress stuffing or the herniation alleviate the pain? Does the laser do something equivalent to cauterization?
Yes, so great question. The laser, the end of this laser right here is a little glass fiber, right? And then it ends. It's literally transmitting energy to the end right there. And whatever I touch with the end gets vaporized. So what does vaporize mean? It means the energy is transmitted like a lightning bolt to the tissue. And then the tissue just gets all that energy, and suddenly that energy causes a sudden energization of molecules within the annulus or disc material or scar tissue. And they absorb that energy, and then they just break apart. So laser energy vaporizes tissue by breaking covalent bonds between molecules, okay? And then the second thing it does is it uses a pressure wave to just blast things. So once I break the bonds, it literally blows the tissue that's been broken up apart and scatters it. So then the water that you're seeing, there's a bunch of fluid in here, and it's constantly going in and out. And that, yeah, thank you. That irrigation actually takes the pieces of tissue and it releases them outside the body, okay, outside the tube. So it's like taking a quarry where they mine like diamonds or rock, and you're blasting the rock first, and then you got to transport it out, all those little blasted particles, right? And so the transportation system we use is the irrigation or fluid flowing through the tube back out. That's usually what gets on my feet, and why I'm usually yelling at Luis to to make it better. All right, we're done at this level. So we've done 1 out of 4 discs, which actually we're doing 3 discs, but we've done one side of one of those 3 discs. I want to try to suck the fluid out. Sorry, why is the fluid not sucking out? How good is our suction going, guys? It's good? It's just very slow. All right, there it goes. No, we're good, we're good. All right, scope off.
Lights on, please.
So that's the first side, the first laser treatment for the first tear. Okay, and that first tear is on the left at L45. We're going to do the other L45 momentarily, but I want to finish the left side, which is 3-4. So just to reiterate, this patient has damaged 3 discs. Actually, they've damaged about 6 discs, but only 3 of them are causing symptoms. We're not dealing with the ones further up because he has no pain and no symptoms coming from them. I've already determined that based on the physical exam and interviewing him, right? Talking to him and examining him. So all of his pain in his back comes from this area. And we've already tested the 3 discs that I thought were causing pain, and indeed they are. This one causes 12 out of 10, 10 out of 10, 9 out of 10 pain. So 3 discs with 3 different pain profiles. But they're all causing us pain, and the reason they're causing the pain is the tear. It's called the annular tear. We need a little more pressure here.
Yes, sir.
So the annular tear is the source of the back pain. And if this was in the neck, it would be the source of neck pain. So a herniated disc in the neck, a herniated disc in the back, a herniated disc in the thoracic, it's all the same. They all cause pain in the neck, the thoracic, or the back through the same method or mechanism. And it's the inflammation within the annular tear. And the annular tear I'm talking about is the one in the back of the disc, not the ones in the front or side. Don't waste your time fixing those because the patient won't get any better. All right, do you have any more questions?
Yes, so they're in Santa Ana, California, and then they also ask, once the tear is debrided, what prevents another tear?
Okay, great question. So once the tear is debrided, what prevents another tear? So the tear forms from trauma to the disc. Trauma comes in the form of a car accident, rear ending, a fall. You know, if you want to know what causes trauma, just go to YouTube and look up Fail Army and watch a couple of the Fail Army videos. And you'll see how common trauma is, you know, whether it's jumping off a roof into a pool and missing, or it's riding a bicycle off a jump. The point is that trauma is common in everyone's lives. And it doesn't have to be major trauma, it could be minor trauma. And basically a traumatic injury to the spine causes the bones to move in opposite ways, and that causes the disc annulus to tear if the traumatic injury is strong enough. So basically, the trauma we're talking about is an injury to the annulus fibrosus shot. And once you injure your annulus fibrosus, the next thing that happens is the nucleus pulposus pushes through the tear and wedges itself in there. And once that nucleus pulposus is wedged in there, it does not go away on its own. It starts to create what's called an inflammatory reaction within the annular tear, and it's that inflammation within the annular tear that causes all the back pain. Once again, the animation for this will be released probably this week. I've been meeting with Zach now for several months. We've been developing the animation, and we're about to release it. It looks like this is stuck right here. Hold the pressure, give me a 11 blade. So finally, we're after months and months of working on this educational animation, we're going to be able to release it, and people will then understand what's called the pathophysiology of back pain, okay? And neck pain. So it's not just for lower back, it's also for neck, shot, and it's for thoracic, okay? Thoracic disc herniation, annular tears don't cause pain that often because that part of the spine doesn't move that much. So it's not that common. And when they do happen, they're usually asymptomatic. They don't cause any symptoms. But there are people with thoracic disc herniations that have constant pain, and it ruins their lives just having that pain, and they have no way to fix it because the doctors just put them on painkillers, and the painkillers won't fix the pain. All they do is just maybe help the pain for a short period of time, a few hours, and then they got to take more painkillers. So the cycle of dependence on painkillers for treating chronic pain is wrong. We can't be treating patients with chronic pain that way. It doesn't work. It doesn't cure them. The only thing that's going to cure these people is fixing this tear the way we do at Deuk Spine. We do get people from California as well. They travel here. I would say probably 50% of our patients come from out of state, out of the state of Florida. They travel here to get surgery because this is the only place they can get it done. We had a lawyer whose daughter was a professional skier. I don't know if that's the right term. Skier, right? Yeah. Anyway, she had back pain for years, and every doctor in California misdiagnosed her. They said it's a muscle strain, but it wasn't. She had a bulging disc at L4-5, and her pain was right there at L4-5. And they were giving her narcotics. I mean, this is I think 15-year-old, 16-year-old girl whose life was ruined. She couldn't play basketball. She couldn't ski competitively anymore. All she did every day was get up and be in pain and go to school in pain. Can you imagine that life? It's horrible. So the doctors there had no clue why she was having pain. They called it muscle spasms. They called it, it's in your head. Go see a psychiatrist. Deal with it psychologically. It's craziness. And all we did was go in with this laser and fix one disc, and her pain went away immediately. Her life changed. And so, yeah, that's why we broadcast, just so you all know, is so people can start understanding that there is a cure to back pain as long as you get the source of the back pain. The source is hard to tell. Yes, I understand it's not easy, but if you have the right doctors in the team, the right diagnostic tests, MRI, EMG, X-ray, when necessary, physical exam, when you have all those things done properly, you can make the diagnosis of chronic back pain 100% of the time as to what's causing it. And every cause has a treatment. So I'm going to tell you something. All we treat at Deuk Spine is really back and neck pain. How many cases of fibromyalgia? Fibromyalgia is a condition where you get pain in your soft tissues. And the truth about fibromyalgia is the source of the pain, whatever it is not curable. How many cases of fibromyalgia, non-curable back pain, have I seen in the last 10 years, treating at least about 100,000 patients? How many fibromyalgias do you think I've seen? Let's poll the internet. Let's poll our viewers. Who wants to venture a guess? Fibromyalgia cases seen at Deuk Spine in the last 10 years. And now pay attention. I'm not saying patients who came here and said they have fibromyalgia. He's doing all right?
Yeah, he's obstructing a lot.
Huh?
He's obstructing a lot.
All right, we'll just keep him more awake than if you need to, whatever you need to do. I'm okay with a little movement. The answer is 0. We've had 0. Why? Because every single person that's come here with a diagnosis of fibromyalgia, we actually found the true source of their pain. And you know what it was? It was either their disc, annular tear, or it was the facet joints, or grabber, or it was the piriformis muscle, or it was the sacroiliac joints. Sometimes it's coccydynia, which is inflammation of the coccygeal ligament, which takes a shot to fix. The point I'm trying to make to you, though, is all those diagnoses are curable. And they all are from a specific source. This is a piece of herniation. It doesn't even want to come out so big. Or wide, I should say. Maybe I didn't get it. So, message to the rest of the world. There it is. I didn't get it. It's fighting me. It's really big. I'm trying to twist it out. Oh, there we go. All right. All right. It's a little firm. That's a herniated disc right there. Okay. How did it get back inside the disc? Because I shoved it in there. Why did I shove it in there? Well, remember I put the dilator in, right? And that pushed it back in. Why would I want to do that? Because it's a lot safer to take a piece of herniation out from inside the disc than it is inside the foramen, where the nerve root is. You can actually damage the nerve root trying to grab that thing. So this technique that we use, and this is not my technique, there's another piece of herniation. It's called the inside out technique, was taught to me by Dr. Anthony Young. Okay? So what's unique about what we do here is the annular debridement. But the actual approach, what you're watching, transforaminal, I did not discover. I used that transforaminal approach to do my annular debridement. But the transforaminal approach was discovered by Dr. Parvis Cambin in Pittsburgh. And Dr. Cambin was a spine surgeon, and he's the one who figured out you can go through the neuroforamen to get to the disc. Okay? And he was the earliest pioneer in that technology. And then Dr. Young was one of his students. Dr. Young figured out that you could do it and then start inside the disc. And if you start, there's the tear, by the way, and if you start inside the disc, that it's safer. And so I used Dr. Young's technique inside out, where he taught me to start inside the disc and work your way out. And that's worked really well for the last 16 years I've been doing this surgery. Okay? So inside out technique. All right, what other questions do we have from our audience?
Yes, how do you feel about chiropractors and how in the treatment that they use to help people? What are your viewpoints?
Great point. Great question. So, all right, how do I feel about chiropractors? You know, I have to tell you the truth. When I was in training for neurosurgery at one of the best training facilities in this country, in the world, UF, Gainesville, they all joked about chiropractors, okay? And we were kind of taught among the good old boys and girls that they were a joke. But what I found when I got out and started treating patients with chronic back pain is that these neurosurgeons that I trained with had no clue what was really going on causing back pain, and that chiropractors are some of the most important doctors that are caring for patients with chronic back and neck pain, because chiropractors, they do something called an adjustment. And an adjustment, basically, they're manipulating the joints of the spine, like the facet joints or the SI joint. And the problem is that many times it's the facet joints that are the cause of the pain. And it's not just the joint, it's inflammation and scar tissue within the joint. So the joints stop mobilizing properly, your alignment gets bad, the patient's alignment gets bad, they get this bad posture, which only makes matters worse. So the reality is that chiropractors and physical therapists are two of the most important doctors treating chronic back pain and neck pain. We need them. We cannot successfully eliminate and treat the whole patient's problem without them. This surgery I'm doing is only fixing the source of the pain, but this patient has horrible posture. Many people like this patient have horrible posture because their pain from the disc went untreated for so many years that it shifted their posture, and now their posture needs to be corrected. I can't correct their posture with this surgery unless I fuse them and realign them, which I'm not doing, and it's unnecessary, or I fix their pain so they can have better posture. But they need someone to work with them on a daily basis, and that's what chiropractors do. That's what physical therapists do. So we believe strongly in the use of chiros and physical therapists before and after surgery to rehabilitate these deconditioned joints and muscles that need reconditioning and realignment. So they're very important. Now, chiropractor is not going to fix the pain from a herniated disc like we're fixing now. They don't have surgery skills. They can't do surgery. Some of them like to think they're surgeons, but they're not. But they still have a very important role in treating the whole patient. And that's one of the problems with spine surgeons, is they fail to recognize the need for rehabilitative medicine after surgery, you know, mostly because of their stupidity and arrogance. But that's the truth, okay? I can't fix these people's pain alone. I need a team. And Deuk Spine Institute coordinates that team for all of our patients to make sure that they get the post-operative therapy from a chiropractor and physical therapist that they need to make a full recovery. And that part can take years, folks. You know, yeah, the surgery takes an hour, and I can fix the source of their back pain in an hour, but rehabilitating the patient's posture and gait, alignment, that takes months, if not years, to do, and that's not something that can be done by me in the operating room. So chiros and physical therapists are 100% essential for the complete treatment of the patient. We use them on all of our patients, in case you're wondering. What other questions, John? This is L34, left side.
There are no further questions at this moment.
Just about done here. I just left the foramen there for a brief moment, trying to just get the rest of this herniation. You can see how ugly it is. This is not a normal looking disc. It's a very degenerated disc. Let me have a grabber. So I'm almost done with this left side. Next we're going to move to the right side and get the right side done. I couldn't even get that piece out. It's too big to fit. Pieces that are too big to fit, a lot of times I can grab them and just take the whole scope out, and then they come out, because the cannula that we work through, this tubular retractor, is actually bigger than the endoscopic cannula. You can see all those pieces of herniation. Just now that we've freed them up, they're kind of floating out. Take that. That there is going to be going to the nerve root, which we don't want to mess with. There's a little bit more that I can get, and then we're pretty much done. Just have to be really careful. You can see all the fat's gone. That's what we call atrophic fat, atrophy fat. It's atrophied because there's been pressure on it for a long time. And the thing about fat is it doesn't like pressure. It doesn't like cold, as you probably know from that sculpting, whatever it's called, that machine that sculpts the fat out of you. It doesn't like cold and it doesn't like pressure. So basically, the narrowing here that this patient's herniation has caused, that narrowing has resulted in the fat atrophying. Atrophic fat, atrophied fat. So that's why you don't see, compared to the last surgery we did, remember the fat was like little diamonds, real glistening little diamonds. That fat around the foramen. Why is there fat in the foramen, by the way? Anybody know? Energy source, right. And what's it the energy source for? The nerves, my gosh. You could have been a neurosurgeon. If you want to be, you can still go do it. One of our nurses is you should be on Jeopardy or something. All right, scope off. So you're right, the nerve root and the dorsal root ganglion specifically is the most important one of the nerves. The dorsal root ganglion is where all the cell bodies of the nerves that, go ahead, pressure, that actually control feeling. You're going to see that in our video animation that we're releasing this week. Okay, so look for it and you'll be able to understand how a annular tear herniated disc causes chronic pain by causing inflammation. Bring it in. Causing inflammation within the annular tear, which those signals go up to the brain via nerves called the sinovertebral nerve, little branches of the sinovertebral nerve, and those branches of sinovertebral nerve that innervate the back of the disc go to the brain via what are called somatic afferent pathways. Somatic afferent pathways. There's two types of sensory fibers in the human body. There's two types of feeling nerves. Sensory nerves are the nerves we use to feel things. Anytime you have a tickle, a tingle, an ache or pain or a numbness, any kind of feeling you have, hot, cold, anything, it's those feelings get to your brain via little nerves. They're called sensory nerves. And if you can tell, and there's two types of sensory nerves. There are what are called somatic afferent and visceral afferent. Two types, somatic afferent and visceral afferent. Visceral afferents typically go to the viscera or guts. And when you have a problem with your gut and you're feeling pain, normally you cannot localize that pain because the nerve fibers are called visceral afferent. They don't go and project to the part of the brain that lets you localize the pain. Sean? Okay, and that part of the brain is called the primary somatosensory cortex. It's located in the parietal lobe, and it's the first gyrus in the parietal lobe. Shot. So the ability to actually feel pain, feelings, pain sensations that localize specifically to a part of your body, Sean, where you can say, ow, it hurts, like my tooth hurts really bad. That is pain transmitted through somatic afferent nerve fibers, sensory fibers. Sean? Okay? And on the other hand, where your gut, you kind of feel bloated sometimes, your belly hurts, but you can't really feel exactly where it's coming from, those pain signals are traveling via what are called visceral. Blood pressure is good. Visceral afferents, okay? So visceral afferents, the key difference is visceral afferent fibers don't project to the primary somatosensory cortex, cerebral cortex. They project to the medulla oblongata, the midbrain, and the pons, basically subconscious, subcortical areas of the brain. So the pain signals that travel along visceral afferents never make it to the primary somatosensory cortex. Therefore, your brain can never tell exactly where they're coming from. It just feels like they're coming from the belly or the leg or some diffuse area. Okay, that's the key. And Deuk Spine, we're the first ones to put all this together and really understand why back pain can be so localized and why it can be localized in terms of the source and why it can be treated and fixed with this surgery. So we're inside the L45 now on the patient's right side. Things are going well. This disc was 10 out of 10 pain. When I tested it earlier, for those of you who weren't here, it literally almost took him off the bed. And he said, how bad is that? 10 out of 10 is what he said. So 10 out of 10 is the worst pain of your life. So you can see, I said, where'd you feel it? And he said, in my lower back. All right, he's moving around a bit. I know you don't want him to get... Yeah. So do you want me to wait, or what do you want to do? I mean, let me see what I can do. Shot. Yeah, we don't want him obstructing, that's for sure. All right, good. I'm in, like Flynn. He may settle down now. Shot. All right. So, just carrying on with my conversation with you all to understand why some pain is very specific. Your brain perceives it as being highly localized and very painful and sharp, whereas other pain is dull and non-localized, okay? All these doctors around the world call back pain non-specific, but they're wrong. The only reason it's non-specific is because they have no clue what the causes are and how to specify it. They're not trained properly. They don't have that experience and knowledge. I didn't get it in my training. I had to learn it afterwards by meeting with experts and then, of course, treating patients. Once you start treating things in the back here that cause pain and you start removing them, you start learning, oh, wait a second, now I took that out and the pain's gone. Wow. Oh, there it is again. It happened again. And, you know, not to make myself sound like the mad scientist, but I used technologies and techniques that were well established, like endoscopic spine surgery and removing herniations. I went a little further and I debrided the annular tear. So it's not like I did something that's totally off the wall. I did something a little different than the way other people did it, and it turned out to be better. And then I asked, why was it better? And the answer came back, because I'm treating something that other doctors don't do in a way they don't do it. That's with the laser. So the laser treatment itself is very important. A lot of people don't understand how the laser works, and they think it's not necessary, it's just a gimmick. Okay, there are a lot of people now that say they do laser surgery. They're full of it. They don't do laser surgery. It is a gimmick for them, but it's not a gimmick for us, because you can see me using it the entire surgery. It's the most important tool I have. But there are companies out there that would have you believe that they do laser surgery when they don't. They just do typical back surgery like a microdiscectomy. And they say they do laser, but they really don't. They probably don't even have a laser in the room. These laser machines are over $100,000. And renting them is very expensive, but I bought ours so I can make sure we always have it available. And I wanted to make sure I had the best. So I'm a bit of an obsessive compulsive about making sure everything is the best it could possibly be. So we have the very best laser, medical laser, that could be used for this procedure. Okie dokie, I've been talking for a long time. It's time for Willy Wonka to take a break. By the way, are there any more questions?
Yes, a viewer is wondering, can the laser also remove bone spurs or osteophytes, or can it only take away the herniation in the disc?
So the laser is powerful enough. The question was, Dr. Deuk, can the laser remove bone spurs and osteophytes, or can it only remove the soft disc? The answer is the laser can remove any bone spur we want it to remove. There's one right there, as a matter of fact, I'm removing right now. I'll show you right there. Okay, removed. Now look here at the tube. There's little marks on the tube. Those are melted steel, and what melted the steel was the laser. Okay, just so you know, the laser. Now this is what happens when you start removing bone spurs. You get bleeding. And so what I found is that bone spurs really don't cause problems. They really don't. Yes, most doctors think bone spurs are the problem, but they're not. It's actually the tear, and the tear is soft. So we don't need to worry too much about bone spurs unless they're right on the nerve, which is extremely rare. I apologize, we're going to have a little bit of red here, but that red is just some bleeding from the end plate, the bone, and that's because I zapped a little bone spur. All right, let me see here. Okay. Here, take this. What I do is I can bring this grab or pituitary in, and a lot of times that will help me see what I need to see better. So, laser. And I know how to work with these conditions. I'm sorry the visibility is poor for the viewers, but there's not much I can do about it right now. I just have to keep working. First time this happened, I kind of remember many years ago. I'm like, oh boy, what do I do? The reality is that there's so little bleeding going on here. That's a herniation that I pushed back in. There's so little blood, it's not a bleeding issue. But it's a visibility issue for the surgeon. So it makes it harder for me to see. That said, I've learned a few tricks to improve the visibility, like putting this grabber in. It actually blocks the flow of fluid, and it just stops the bleeding for a moment to allow me to kind of see better. Thank you. But in the end, the good news is that the pathology that I'm trying to remove is actually located in the same place every time, which is at 12 o'clock, you know, from about 11 to 1 o'clock, which is up there at the top there. That's where the tear is, okay? So, fortunately, as long as I keep my endoscope aligned properly with the 12 o'clock position and the laser up there, I can treat all that. without having to see it tremendously well. Because I'm inside the disc, so I'm in a safe area. I'm not worried about the nerve root getting damaged in here. The nerve root's not inside the disc, it's just behind it. So as long as I remain inside the disc, I don't have to worry too much about injuring the nerve root. All right, what other questions do you have there, John? It's kind of like flying a plane through a storm. You may not be able to see the landing strip, so you have to fly with an instrument panel. It takes more technology, more knowledge. It's more difficult to do, but it's still doable. Great questions from our audience today, by the way. Standby laser. There's a herniation there. Question is, can I grab it or not? Nope. Zapper. All right. Any more questions? John?
No, there are none at this moment.
All right. So this is a particularly long surgery, by the way. This is as long as they got with the laser surgery. The only reason I agreed to do this surgery this long was because this patient traveled from out of the country to come here and have laser surgery done by Deuk Spine Institute. So I wasn't gonna just do one disc and then make this patient come back again to do a second or third. What's going on with irrigation? Stand by. All right. So normally we do, about two discs, but this patient needed more. So we agreed to do them all. And it just makes for a longer surgery. So hopefully you all can grab some popcorn and soda and relax. Also, what makes this one different is the fact that, what are you doing over there? You're like pumping away. All right. The other thing that makes the surgery different is the blood, which is the red stuff, in case you were wondering. And again, normally we don't have this kind of blood, but this is what happens when you start getting into bone spurs, and it becomes a pain in the butt to deal with. All right, I'm gonna have to slow it down. And the total bleeding we're seeing is minimal. It's not clinically significant. Like I said earlier, all it does is obscure my ability to see what I'm doing. That's probably about the last of the tear right there. I'm just trying to grab out any of the herniation I can. It's always better to remove whatever herniation you can with the grabbers, because they can remove a lot more herniation than the laser can. The laser just takes forever. So the big stuff you want to get with the grabbers. Now I'd love to be able to close off the end of this cannula in order to be able to see better. But if I do that, it affects my ability to maneuver the laser around and zap this annular tear and clean it up properly. So unfortunately, I have to deal with this lack of visibility by just taking peeks here and there rather than stopping the flow of irrigation. It's actually the flow of irrigation that keeps moving the red stuff out. After we do this disc, we'll have one more to go, and then we'll be done. Okay? can see what I mean by improving the visibility. By putting in the grabber. Putting the grabber in just basically arrests the flow enough. Once again, this is all due to me zapping a bone spur or a little piece of bone spur basically, that was deep in there, which I kind of regret doing at this point, but I think it made things a little worse in terms of visibility, making the surgery a little harder to do. But we'll still get it done. All right, what other questions do you have from the audience? John?
Still no more questions at this time.
No questions, all right. Well, hopefully the students in Santa Ana, I believe they said, or Santa Clara, California?
Yes, they had to go take an exam.
Oh, okay. Very good. Yeah, they reached out to me and Deuk Spine over the weekend, and were just saying how much they appreciate, you know, watching these surgeries and learning. So we're happy that they are. Just about done here. But you can see you can't just put the laser down. You actually have to guide it. And the process is a true surgery because I'm not just shoving the laser in. Now the old IDET procedures, intradiscal electrothermoplasty procedures that are not really covered anymore and they don't really benefit people, those procedures were done blindly. The doctor, usually a pain management doctor, would literally just put a needle in the disc and stick a laser fiber down the needle and just leave it in there and zap it 3 or 4 times, and then they were done. And those procedures really didn't do anything. They didn't help the patient. So they stopped doing them about 15 years ago. We don't do those procedures. We do a true surgery. And a true surgery requires being able to see what you're doing, visualize it, and get feedback, right? You need to have feedback. Feedback is very important. All right, that's the last part I want to do right there. So what feedback means is you zap and you see the effect. So you intervene with something like a scalpel or a grabber or a laser, and you see the effect of that, and then you move to another area, and then you keep, you know, it's like playing tennis, right? You hit the ball to the other side, but you got to be paying attention to where it goes and what the other player does with it. So you have to constantly be watching and assessing and processing information, feedback, and making decisions based on that. You can't just hit the ball blindly and it, you know, guess where the next ball is going to come. You got to constantly assess that ball position and the position of the other player. So I rely on the same type of feedback from this laser. I need to see every zap and what happens with the zap. How's his blood pressure? Good? It looks really good. Yep. So we want to see every zap of the laser. We want to see the effect of the zap on the annular tear and the, you know, herniated disc material or bone spur if that's what we're targeting. And we want to get that feedback and constantly use that information to plan the next zap. So I'm constantly assessing, you know, what's happening and redirecting the laser by moving the laser with my fingertips. to ensure that every laser blast is productive and on target. That's kind of the difference between surgery and just sticking a piece of metal in somebody. Right? A surgeon actually directs the treatment, and somebody who sticks a piece of metal in another person is not really directing the treatment using feedback. Are we ready?
Yes.
All right, so the last disc to do is the L5S1, and we're going to do that one next. Yep, put pressure. Keep the pressure
Yes, sir.
just for a few more minutes. Shot. Perfect. Stay there. We're going to take the needle out, leaving the guide wire. The use of guide wires in spine surgery is something that was developed during my tenure as a resident in neurosurgery. In other words, that was something, a technology that was being developed at the time that I was in my training. Shot. And we were using guide wires primarily to place screws in the spine. Shot. Shot. That's just so horrible, huh? The way it looks. Just, but it's all the wag and the orbital stuff. It's really not the anatomy. Shot. Okay. So, the idea of using a guide wire is not my idea. It's not original to the Deuk laser disc repair. It is a tried and true, established way of doing surgery. Is that it? So, if you look at this, it come off now. If you look at the treatment, it's actually, he's moving a lot now. He's not happy with that shot. And it looks funny because it's actually higher on one side than the other. Let me know when you think I can progress, okay?
I think you're good.
Go now or wait?
I go ahead. Give me a little
Shot. I can't see. Move. Oh, he's not happy with me right now because we just went through that. That was a 9 out of 10 disc pain at L5S1. So the good news is we're in the disc with the dilator. The dilator is a special tool that basically spreads tissues open and doesn't really damage them. It actually just spreads them. So again, a dilator is another technology that's been used in medicine for many years, shot, where I mean, the concept of spreading tissues rather than cutting them has been around for a long time. Just about done. Shot. Should be good. So I'll show you what I'm talking about. Look here. See this tip here, John? Go ahead. You can take it out.
On the x-ray?
No, no, no. Look here on the eye in the sky.
All right, we're overhead now.
Okay? Can you see this?
Yes.
So which one can I use? So look here. The tip of this thing is tapered. It doesn't go to a sharp point, but a nice blunt tip, and then it spreads for this zone right here, and then it's a even diameter through the rest. Come on, get yourself organized. Okay. So it doesn't cut tissues, it spreads them. And when you're done, it lets you put them back to the way they're supposed to be. Okay, the tissues just fall back together. So this surgery you're watching uses a variety of technologies that were developed by other people to do the exposure, like the tubular retractor. That was one huge discovery. Tubular retractors. Again, not discovered here, but they were discovered by somebody else, using a retractor in the shape of a tube, rather than the standard surgical retractors which rip tissues apart. The tubular retractor is gentle and it holds tissues apart in a circumferential manner. So it distributes the pressure and force on the tissues in a very equal way, so it minimizes trauma to the tissue, right? Because other retractors retract on point, on a specific pressure point. And the area of the tissues would get retracted with the other retractors, like the typical retractors, the old retractors. Those tissues that were pushed against by the retractor blades, they could be damaged because of the pressure. But by having a tubular retractor, that pressure is spread out around, around the entire area that you're operating, all the tissue. So it kind of gets an equal share of the load, if that makes sense. So tubular retractor is the most advanced, most ingenious retractor system in the world. And that's what we use. Guide wire, one of the most advanced technologies in spine surgery. For minimally invasive surgery that's very safe, you use a guide wire. Okay? So you're starting to see this surgery you're watching uses parts of other surgeries that were developed before this surgery that allowed me to do this surgery safely. The thing that I developed that's the most important that we developed here at Deuk Spine was the annular debridement. No one else has ever done it. No one taught it to me. I had to learn it myself. And when we started doing it, patients' back pain went away completely. Their neck pain went away. The only way to get rid of pain in their disc is from an annular debridement. That's all herniated discs, bulging discs, degenerated discs. They all cause pain through the same mechanism, the annular tear. There is no other way. The way they cause axial pain, which is back pain, axial neck pain, is through inflammation in the annular tear. The way that cervical disc herniation causes headaches is through inflammation of the dura behind the disc, and it spreads up around the head. The way that they cause leg symptoms or arm symptoms is inflammation of the nerve roots. Okay? So inflammation of the annular tear, back pain, neck pain. Inflammation of the dura behind the disc, headaches. Inflammation of the nerve roots, arm and leg pain, numbness, tingling, weakness. Compression of the nerve roots causes just weakness, usually, or numbness. Okay? Can cause also bowel and bladder dysfunction. Compression of the spinal cord, loss of balance, loss of strength, loss of sensation, loss of bowel and bladder control, and loss of respirations if it's high enough. So those are the lessons. So you're all going to be smarter than the average neurosurgeon with all this knowledge. Almost done. This is our last disc. I'll be done in 5 minutes or less, okay, doctor? So we're just wrapping this up. We've done 3 already, 3 tears. This is the 4th tear and the final tear. Come on. I hate it when those little pieces of tissue just dance around. We don't want to watch you dance. Get lost. Get out of the tube. The only other way to get them out is if they don't float out, you have to grab them with the grabber. And I don't want to stop lasering to grab them. So I'm happy when they float out. All right, so this is our second surgery of the day. Believe it or not, we've got 2 more to go. Hey, everybody grab some pizza. We've got luscious, delicious, unhealthy pizza. From Papa John's. Okay? Well, I splurged today. It's unfortunate that Nico's closed. They went out of business. They used to make some great lunches for us. Just might have to hire a chef. All right, this is the end of the tear. And you can see there's some fat tissue there. See how quickly that normal tissue gets ablated by the laser. What takes a long time is the scar tissue. Scar tissue just, for some reason, it's just very dense and thick. It's very hard for the laser to get rid of it. Still does, but you know, the other thing I could do is ramp up the power, which I don't want to do. Okay, but ramping up the power could be, you know, cause, you know, some issues. You can have, the bone can die from too much energy being transmitted. It can cause a lot more damage than good. So right now at the power levels that we use, it's very safe and it gets rid of the bad things but doesn't hurt the good stuff. Like any type of an energy source, if you deliver too much energy, you can cause damage. I can see there's no damage being done. I can see that the energy being delivered is just coming out at the tip of the laser, which is about 0.5 millimeter, and it's not doing any more damage than that. Let me see if I can grab that herniation there. Okay, I think we're pretty much done. If you have questions, feel free to ask them. That's what we're here for. I'll do my best to answer them for you. But we've treated 4 areas on 3 discs in a patient with back pain. Anybody know how long his back pain was for? Anybody? Bueller? Bueller? Huh? I want to say it's been going on for a long time, if I remember correctly, but I don't want to assume that. Speaking of which, I was in Wisconsin at Road America. I got to tell you, I mean, the weather there is amazing up north. Literally 70 degrees. While we're all struggling out here with 95 degrees and humidity. They had no humidity, 70 degrees with a gentle breeze. It's the most beautiful weather I've ever seen. I mean, it just reminds me of Europe. It was. Where is that? Where you're from? Wisconsin? Yeah. Well, I don't disagree with you. The wintertime's probably a bear. But I mean, just to live there in the summer is probably really nice. Okay, we're done. Thank you, everyone. I appreciate you sticking it out. If you have questions about the surgery, write them down, and I will do my best to answer them in the next few minutes. We're going to do a quick live feed where I'll come online and talk to you and answer questions. So this is when you should type them up. I'm very happy. The surgery went better than I thought it would. It was really hard because of the scoliosis to get in to the discs and to fix them. But once we got in there and to the right place, the rest of it's the same as it always is. You know, there's really no difference. We've lost probably 10 cc's of blood. This is a little more than normal, but not bad. Put pressure, please.
Yes, sir.
Okay, so I'm going to call blood loss 10 mil. And we got done whatever we originally set out to do, which is good. I've got one Ray Tech off the field. Go ahead and type up your questions, and I'll come answer them for you, folks. And we got another 2 lasers to go today. How come this is not staying open? Is that garbage? Yeah. Well, thank you.
This is the one from OR1.
All right, Dr. Deuk here, just wrapping up another surgery at Deuk Spine Institute on July 13, 2021. This case we just finished was a patient who had back pain for years that would go from the back down into the legs, primarily the left side, with numbness and tingling, and from the knees down on both sides. Now, when we looked at the MRI scan to figure out why is this patient having these symptoms, it was obvious to me that he had problems with the discs. And if you want to know what a disc is, if you look here, bone in the spine, a disc is a cushion between the bones. And you've got basically 5 cushions in between 6 vertebrae in your lower back, and these things keep going up to all the way to your skull. So the lumbar spine is the bottom 5 bones, then you get the thoracic spine, which is kind of like the mid back, and then you get the neck, which has 7 bones and 6 discs basically. So in this patient, when you try to figure out why is this patient having so much back pain, there's really only a couple of causes of chronic back pain, and the most common by far is a damaged disc. Let me just show you what I'm talking about. Take the disc out from between the bones and look at it. This is the front view, this is the back view. Basically, this is the top-down view. And you can see that when you have a herniated disc or bulging disc, it all starts with a little tear in the back here, where the jelly in the center pushes through the tear, causes a little hump of jelly. That jelly is basically, when the tear happens, the jelly wedges in there and the tear can't heal. So The pain that comes from a herniated or bulging disc comes from the annular tear. It comes from the annular tear because the annular tear is trying to heal with inflammation, cleaning up all the debris in there, and it never can because there's too much jelly stuck in there. And then, of course, people reherniate, they get a second herniation or third that builds on the first, and they get more mass and more material. So I went in there to help the disc heal, basically, as the friend of the disc. I went inside with the laser, I found the tear, I found the jelly in there, and I cleaned up that tear, so now the tear will heal. So there is a gap there between the edges of the tear that will fill in over time, and the gap will fill in with the same thing that the annulus is made out of, which is collagen. And there's many different types of collagen, but the most common type of collagen is type 1 collagen, all right? And so the tear will heal up mostly with type 1 and some type 3 collagen, which is the same thing that the annulus is made up of anyway. Once the tear is completely healed, it takes about a year to fully heal. That tear won't happen again unless the person has another major traumatic injury. So the idea is debride the tear, get rid of the pain, let the tear heal, and that should, once it's healed solid, it usually takes 6 months to a year, then the pain shouldn't come back, all right? So do we have any questions?
Yes. Other than a surgery being longer, what other complications make a surgery involving multiple radiations more difficult?
So what other, somebody said complications, but I don't think complications is the right word. I would say what other features of a patient or their condition could make the surgery longer? Well, there's a lot of things that can make the surgery longer, and the list is long. So I think the most important is anatomical considerations. So, for example, a patient that is really heavy set, a lot of soft tissue, larger patients, the spine is deeper. You got to go through more tissue to get there. That makes it harder. The spine being shifted further forward, away from the back, further forward is going to make it harder because of the angle of approach. From going from the back here, kind of going in, is going to be steeper and it's more difficult to get in. Deformity of the spine, whether it's, if you're talking about bending of the spine or twisting of the spine, like scoliosis, all those things change the target that I have to get to, which is right there. Anything that makes that target less accessible is going to affect the length of the surgery. And so these joints are called facet joints, right there. Forget about the screws and rods, but if the patient's had a prior fusion, the screws and rods could make it longer. The scar tissue around the screws and rods can make it longer. The bone growth around the screws and rods can make it longer. The facet joints hypertrophying, the capsule hypertrophying make it longer. The spine twisting away from my needle makes it harder and longer. The disc space right here collapsing, watch, it's collapsed, right? It's harder to get into, that makes it longer. The patient, whether they're large or small, makes a difference. Smaller, skinnier patients are easier to get to. The spine position in the patient further forward makes it longer and harder. More levels, when I'm doing 1 level, it's a lot quicker, easier than doing a 4-level surgery. So we don't turn people away because they're hard. Even if I had lots and lots of patients to operate on, I don't think I would still turn them away. Obviously, I want to help everybody, and I don't hold that against them. I don't even turn away people with a bad attitude because I know chronic pain affects their emotions and their attitude. So as a physician taking care of people who are suffering, I do everything I can to basically facilitate them coming in and getting fixed, no matter how hard it's going to be. Nobody said neurosurgery was easy. No one said spine surgery was easy. Nobody said medicine was easy. We all knew it's hard, and it's hard to take care of people. That doesn't mean that I give up and I run away from that responsibility.
take it very seriously, and I always want to do my very best for the patient. So I'll stick it out as much as I can, as humanly possible, but I also have to balance my enthusiasm for success in helping the patient with the possibility that I could be harming the patient by trying too hard to get there to do something that isn't going to happen without causing damage to the patient. So a good surgeon has to recognize their limitations and understand that you're not going to fix everybody, that there are going to be situations that are not possible to rectify with the resources we have available, whether they're surgical or medical. We're not going to be able to fix everybody, but we have to do our very best, and I feel that that's what we do here at Deuk Spine.
That's all.
That's our last question. So I'm going to take a moment to powder my nose and get ready for the next surgery. All right, talk to you soon.